Do you want to know more about how you can eat for better health and longevity, and how your diet and lifestyle can play a part in chronic disease? Then you're in the right place. I'm Claire Day.
And I'm Daisy Lund, and we are both plant-based doctors with a passion for improving nutritional education. In this podcast, we will bring you all the latest medical evidence on how a plant-based diet can improve your health whilst being kinder to the planet and fairer to the animals that we share it with.
Twice a month, we bring you interviews from experts in the field with a focus on an important topic related to plant-based health, all while sharing recipes and food ideas.
So, welcome to In a Nutshell, the Plant-Based Health Professionals podcast.
Hello everyone, and welcome to episode 13 in the second season of In a Nutshell.
This week, we talked to Dr. Hannah Short, a specialist in women's hormonal health. And as you can imagine, this specialism covers a lot of areas. But for the purposes of this episode, we were talking to Hannah about the disruption of periods in terms of mood and discomfort, and when women should definitely be seeking help and what that help might look like.
Without giving too much away, have you changed your practice since listening to Hannah, Daisy?
Yeah, well, definitely. It certainly made me think that I should be taking cyclical symptoms more seriously. So, I've always thought it's sort of normal to feel a bit different just before a period, maybe a bit emotional or craving certain foods or feeling bloated. But moving forwards, I might just be asking patients a bit more about the extent of these symptoms and how it's affecting their daily lives. Given that we found out that premenstrual syndrome, or PMS, may be more severe in some women than I originally thought. So I'm a bit worried that I might have missed some diagnosis of PMDD, or premenstrual dysphoria disorder, which is a more severe form of PMS.
Yes, you hear my shock when Hannah tells us of the high prevalence of PMDD, and I did refer a patient on for it this week, feeling a bit more qualified to recognise it now. I do feel we should give listeners a little primer on the period cycle before we unleash this one, though. We talked a lot about the cycle, which for people who haven't studied it or not studied it recently may be a little confusing. Daisy, I'm going to put you on the spot to go back to your studies. What are the basic things we need to highlight in the discussion?
Yes, I think I can manage that just about, Claire. So when we think of the cycle length, we know that that can vary. But when we talk about day one of the cycle, that's always the first day of a woman's period. And then we talk about phases. So you might hear in this episode the mention of the luteal phase. That comes up quite a lot. And to put that into context, the cycle starts with something called the follicular phase, which can vary in length. But let's say in a 28-day cycle, it'll be the first 2 weeks. That's when the ovary is preparing to release an egg. Estrogen levels are rising and the lining of the womb is building up. Then comes ovulation. When the egg is released, estrogen levels drop and you're in the luteal phase. The progesterone hormone takes over and you make more. But if fertilization doesn't take place, the levels of progesterone will then drop, leading to the shedding of the lining of the womb and the start of the period. So we really did focus on this time from ovulation as being the more fluctuant part of the cycle.
Armed with that refresher from Daisy, I think we're good to go, listeners. So today we're welcoming Dr. Hannah Short to the Nutshell, a GP specialist in menopause, premature ovarian insufficiency, and premenstrual disorders. She's got an impressive range of expertise in women's health, and so there's so much we can talk about. But we're going to start by covering in simple terms some of the problems women experience with periods before the menopause. So Hannah, as GPs, we're very excited to speak to you and get some plant-based guidance in this area. Now, I love your writing on how plant-based diets and values fit into your work, and that we can be holistic with this without preaching to our patients. And I think this couldn't be more relevant, having seen the consequences for Dr. Sarah Ben, who was recently suspended following her action on climate change. So please tell us about how you came to stand proud as a vegan doctor and how you came to specialise in women's health.
Okay, hi Claire and Daisy. Thanks for having me on the pod. Oh gosh, it's a bit of a long story, so I'll try. I'll try not to take too much time up with the how I became vegan and how I feel it influences my work as a doctor. But the long and short of it is, I wish I'd become vegan sooner. But I grew up on a farm with animals, and in ironically, perhaps that's kind of probably what led me to veganism ultimately. But it took me a while. I was always concerned about factory farming because I grew up on a small holding and it had been instilled into me the importance of animal welfare. So I was very keen on that aspect of things. And I suppose I didn't really question whether we needed to eat animals because it was the way I'd been raised. I grew up in a farming community. I didn't see factory farming where I was. My dad was a farm animal nutritionist as well, so I kind of knew a lot about stuff from that side. But as I kind of grew older and I started looking at stuff, I became more and more concerned about consumption of animal products on a wider scale, factory farming from the animal welfare point of view, but also the impacts on things like human health, the antibiotic resistance. I felt for myself that I wanted to kind of live according to my values. And I ultimately, when I realised obviously we don't need animal products to live well and be well, I started excluding them from my diet. And then that opened up a whole new world to me, looking because people were questioning me, well, we're omnivores. How are you going to live well on a completely plant-based diet? So I looked at that and I thought there's such a wealth of evidence here to support this, and environmentally it made sense. And so this is like 8-9 years ago when I went completely plant-based. And I just thought actually this sits really well with the duties of a doctor. If you're looking at the four main things about like autonomy, just beneficence, which means do good, and non-maleficence, do no harm, because as doctors it's not just about the individual, it's about society. If you look at the ripple effects of adopting a fully plant-based diet, the fact it's more sustainable for the earth. I think it's a big thing we could do if we all, if we went towards a plant-based diet, reducing our impact on the earth and hopefully mitigating climate change, which affects the health of so many in the world and will only continue to do so, reduce the risk of antibiotic resistance, and even looking at the human psyche and the fact that when we choose to purchase meat, and particularly from factory farmed areas, the abattoir workers are exposed to such dehumanizing work that goes on behind closed doors, high rates of PTSD, higher rates of crime around slaughterhouses. And I don't know if you're aware of the work of Dr. Asha Akhtar, who's a neurologist in the States who speaks about cognitive dissonance and how this affects us on a deeper level, because most people do care about animals, but there is this huge kind of cognitive divide. And is talking about how it damages a kind of the level of compassion when we don't live with that. So, I mean, I could talk for ages about that, but I feel there's so many reasons why I feel I can say that I'm a vegan doctor, not just a plant-based doctor, it is about the animals, it is about the environment, but also the impacts on people around us as well. But we obviously can't talk about veganism in our consulting rooms because it's a belief, it's a philosophy rather than a diet. And I suppose much as we couldn't talk about whether we were Christian or Muslim or Jewish within it's something for outside that. But I think we can talk about the reasons why I think it sits in line with that. So that was a long answer. But how did I get specialised in women's health? Again, it's a bit of a long story, but I will keep it brief. I had, unfortunately, a long history with pelvic pain and issues with my menstrual cycle ever since my periods began at the age of 13. And I ended up having to have a total hysterectomy and both of my ovaries removed when I was 35 because my symptoms were just, well, completely debilitating, to be honest. I'd had a range of treatments before that, medical, surgical. I had made some changes, probably not with the knowledge I know now. I wonder if I could have done more, but I tried various exclusion diets, had some complementary health treatments, and things had helped for a bit, but never sufficiently long enough. And I think being thrown into an early surgical menopause and being a doctor made me realise that we're not really taught about this when it happens to you at such a young age, that we don't really have the tools to help younger women who find themselves in this situation. And I suppose I just became passionate about learning more and more. And I think, I mean, it's definitely was driven by my own personal experience, and by realizing that I just needed to know or wanted to help others in the same situation.
Thanks for that, Hannah. I mean, we were both smiling there when you were talking about all your reasons for calling yourself a vegan doctor, because I think it's something that we can all relate to in this space. But moving on to your personal journey, I think what we want to do is start off with the fact that women have periods and talk a little bit about what's normal with a period, and thinking about something called premenstrual syndrome. Where do you draw the line between what might be a normal experience and what might be an abnormal experience for a woman getting periods, such as, and obviously you've talked about your own experience, which was really serious. But with PMS, when should women be thinking about getting some help with that?
Okay, so I mean, PMS has different definitions according to where you look, but it stands for premenstrual syndrome, and essentially it's a collection of symptoms, both physical and psychological, that emerge in the 2 weeks before a period. So if we're looking at, say, a standard 28-day cycle, I mean, obviously everybody's different, but say the average woman or somebody of assigned female birth would have a regular 28-day cycle. It ignore these symptoms that occur after ovulation, which is around day 14, and then improve when the period arrives. The thing is, there are around 200 different symptoms that can make up the premenstrual symptoms. So, and there's the biggest ones if we're looking at physical symptoms. The most common ones are headaches, breast tenderness, bloating. In terms of psychological symptoms, it's anxiety and low mood. But I say there's 200. There's so many things because we have nearly all of our cells in our body are hormone responsive. And I think if we're talking about when does it become an issue, well, I think the vast majority of women will be aware that their body goes through a change each month, that they will feel slightly different, whether it's just after their period, whether it's mid-month, or whether it's just before their period. But I think it's about the degree to how much it affects you. Does it affect your functioning? So I think clinically significant PMS will probably affect around 30 to 40% of the female population. That means that the symptoms can be quite uncomfortable, but it wouldn't necessarily be enough to say stop them functioning at work or stop them socializing. But it may be enough to think, actually, what can I do about this? I feel really rotten in the week in the lead up to my periods. I do feel really heavy and bloated. My breasts are tender. I'm much more tearful. What can I do about it? And so there, I think that it's not an insignificant number of people that are affected with it. But these are the people who are going to be probably benefit a lot from things like dietary and lifestyle kind of changes. Sometimes only small things are needed. Sometimes medical help is also needed. But I think it can be quite hard really to work out what's going on. And I think one of the mainstays of things when you're talking about PMS is actually, is this what you're dealing with? And tracking symptoms against your cycle will really give you that picture, because you need to be able to differentiate, is this purely driven by the changes in the cycle, or is it an underlying condition being exacerbated? So there's something called premenstrual exacerbation, or PME. It's not a formal diagnosis, but we can see it. So with anybody who might have a physical condition, it could be that they suffer with migraine, it could be that they have epilepsy, or it could be a psychiatric condition, something like, bipolar disorder, OCD. Are these things worse in the luteal phase, that second part of your cycle? And if that's the case, you probably should be focusing more on managing the underlying condition before trying to kind of look at the hormonal side of things.
That's really interesting. And I think we're starting to uncover how little we know as generalist GPs in helping women with these problems. So, I mean, NHS Choices recommends that you speak to your GP if you're suffering. And we wondered if you could outline a bit how you should handle that consultation as the patient, and indeed maybe move on to how you should handle it as the GP.
I think if you're a patient and you think you're struggling with PMS, the best thing to do would be to track your symptoms, essentially, first of all, so you can show you've got a clear picture. So you can do this. I mean, for me personally, as the doctor, I like to see the old-fashioned paper way of doing this, because I feel it gives you really good, clear representation. But there are lots of apps out there now, and I think a lot of girls and women do track their periods on apps, and some of these do allow you to track your other symptoms alongside that. If you can show for at least 2 menstrual cycles that symptoms that you're struggling with, whether they're physical or whether they're psychological, and normally there'll be a combination of two, then you can go to your GP and say, I'm struggling with this, what would you recommend? And to some extent, depending on what's driving the symptom, what's the worst thing for you, that will influence what's recommended. So if somebody's predominant symptom is breast tenderness, that's going to be maybe a different, I mean, the things can overlap, but it's going to be a different than if somebody's having very severe kind of mood symptoms, for example. Or if it's more fluid retention, again, there are other things we might be looking at more, again, than if it's more of the psychological side of things. And so I think that's the most important thing, is tracking. This is not about hormone imbalance. So there's no point having blood tests, or no point asking your doctor for blood tests unless, and this is when we're coming to what the doctor should be doing, unless we think there's a diagnostic uncertainty, is there something else going on? Because hormone levels are almost always normal. I mean, of course, somebody could have something else going on. There could be thyroid problem. There might be something like polycystic ovarian syndrome, in which case blood tests may be abnormal. But most of the time with a true premenstrual syndrome, then nothing really is going to show up on your blood tests. And it's more really the brain and body's response to the changing hormones, which is a natural part of being born with female reproductive organs, that's the issue. And then that will guide things. From the doctor's point of view, that's what you want to see. You want to know that this is what you're treating. There are guidelines that doctors can look at. So there's the Green Top PMS guidelines, which are published by the Royal College of Obstetricians and Gynecologists, which are very clear. There's also CKS guidance, so some published in 2019. So it's very clear that we need to know that this is what we're dealing with, and it's in the second phase of the menstrual cycle. And then I think as a doctor, it's very helpful to explain to the patient what's going on. Although we don't know and fully understand the true causes, we know that it's the brain and other systems that are responding either in an exaggerated way or an abnormal way to normal hormonal changes. Because I know we're going to come on and talk about PMDD, which is the most significant side. We need to look and make sure that that's what they're dealing with there. But I think an explanation can kind of go a long way, especially if symptoms are at the milder end. Understanding what's happening and working with your body can be really helpful. So obviously after ovulation, mid-month, that's when your estrogen's highest. That's often when women are going to feel maybe at their best. They may feel kind of more energetic, libido, sex drive can be increased, appetite may be increased. And from an evolutionary point of view, this makes sense. And after that, there tend to be two times when people's PMS symptoms can be particularly bad. Directly after ovulation, and that's when estrogen levels just start to fall. And then in the last week before menstruation. And that is because just after ovulation, the progesterone starts to rise. And then in the second week, both the progesterone and the estrogen drop off again quite rapidly. So sometimes, what I sometimes do in clinic is plot very carefully when somebody's symptoms are, because I can then look at actually what is driving, what is likely driving. Is it the fall in the estrogen? Is it the buildup of the progesterone? Is it the drop off of both of them? As a GP, to be fair, it's going to be quite difficult to do that in your 10 minutes. But I think if you can explain to patients that it's the change in hormones, which is a natural part of the menstrual cycle, that's driving that, and we just need to give you some help to manage those fluctuations and give you some tools to deal with that. So, there are the guidelines that are produced by NAPS, which is the National Association for Premenstrual Syndromes. They've been taken from the RCOG PMS guidelines, and they start with kind of things that you want to do on a diet and lifestyle kind of side of things. So which can be quite, I think, empowering for the patient, because obviously not everybody wants to take medication. And I think you often need a multi-pronged approach. So whether or not you go down a medical route, looking at the other options is really important. So sometimes you need more than one thing. So the CKS 2019 guidelines are quite clear. They've got some quite clear guidelines on what you should do for diet and lifestyle measures that can help improve premenstrual symptoms. So that's a diet rich in complex carbohydrates. So essentially a lot of plant-based whole foods and whole grains and things like that can help in terms of the fiber intake, can help steady blood sugar levels and things like that, provide an anti-inflammatory dietary pattern. Often traditionally it's been recommended to have meals, regular meals every 2 to 3 hours, but I think that's because you want to kind of not have blood sugar dips. But again, it doesn't necessarily have to be that regular. It depends on an individual level, I suppose. And they talk about the importance of not smoking. I mean, obviously, we're never going to be recommending that as GPs, but there's definitely association with smoking and developing premenstrual symptoms. Caffeine and alcohol can really disrupt things for some people. The caffeine tends to be quite individual, but definitely alcohol is no friend if you've got PMS, because it exacerbates hormonal fluctuations that are driving the symptoms. And exercise has been shown, especially to help with the psychological and emotional symptoms of PMS, which can be quite difficult for some people. So there's a sleep-wake cycle that is important. So getting out in the natural light in the daytime. We think, like light therapy in winter that we might use for kind of seasonal affective disorder, that can be helpful as well. There is thought to be a slight dysfunction, maybe again towards the more severe end of things like PMDD, with the way the body processes melatonin, which is the hormone which makes us sleepy at night. But so having a regular sleep-wake routine is also really important. There's other things, there's lots of hormonal stuff.
Can you clarify, just for any health practitioners listening, how we might want to use the pill to help with PMS and what we should be saying to patients about why that might help?
Okay, yeah. So if we're thinking back to the guidelines, so you've got the first rung of the ladder, as it were, where you're looking at the self-help measures, that things that can help patients. So some of the things we've discussed and we want, but so you've got that aspect. Then you've got things like these, because when you're looking at managing premenstrual symptoms, it's looking at minimizing hormonal fluctuations, but also altering the brain's response to these changes and encouraging proper hormonal metabolism. And that's where a lot of the dietary and lifestyle measures come in. But sometimes we do need to kind of use medical help to kind of take away the hormonal fluctuation and try, and then you can also concentrate a bit more on the diet and lifestyle aspects. So we can look at, there's two things. There's the hormonal side, so things like the combined pill, but there's also the SSRIs. And there's actually more evidence for using the SSRIs than the combined pill when it comes to managing premenstrual symptoms. And this is partly because we see, particularly with PMDD, so the more severe form of premenstrual disorders, there's an altered way the brain deals with estrogen serotonin processing, essentially. And we know that when the estrogen levels change during the menstrual cycle, so do the serotonin levels, which is more of our feel-good hormone. And anything we can use to stabilise that can be helpful. Interestingly, and what's really important though, the SSRIs, so these are the antidepressants like sertraline, fluoxetine, things like that. You often can use them at a much lower dose, and you only need to use them in the luteal phase of the cycle. So I think a lot of women are worried that their doctor might prescribe them the SSRI. Oh, I'm being told I'm depressed. I'm not depressed. I just feel rubbish in these last 2 weeks. And it's like, nope, it's not. It's a different mechanism of action, and it can often work within hours to days. So to be honest, you can have quite a short trial. You can try it for a couple of months, and if it doesn't work, then you think, well, look at a different medication or look at a different approach. So it works in a very different way to when we're using it for chronic anxiety or depression, where we have to sometimes wait, 6 to 8 weeks for things to kick in. And I think by using a lower dose and just during the luteal phase of the cycle, you can minimize side effects as well, and you don't get that kind of long-term dependence. So I think that can give patients, I think, they can feel a little bit more in control. You don't, it's not like you have to stick at this for 3 months solidly before you'll see a change. You could find out quite quickly. Yes.
Hannah, you mentioned low dose in the luteal phase. I'm really intrigued by this because often I, consider SSRIs take a long time to work, like you said, the 4 to 6 weeks. And so this on and off, 2 weeks on, 2 weeks off is interesting. When you say low dose, do you mean sort of 20 of citalopram? Like, are we talking standard doses or lower?
I often start, so this isn't in the guidelines, but I found a lot of patients with the more significant premenstrual symptoms are very sensitive to medications, which can make managing them medically quite difficult. So I think it's sometimes, maybe I started doing this because of want to give the patients a little bit, they feel like a bit happier to start something when it's low dose. So I'd often start at half the lowest dose, or, when it says in the BNF, for the elderly or children, I would start at the lowest dose. Something like sertraline, I'd start with, say, 25, but even I've had some people go half than that. But I think 25 would be a good starting dose, whereas normally we'd say 50 or something. And I think escitalopram, some people have started on 2.5 milligrams for it. So it's the lowest dose, or even half the lowest dose if you're able to cut the tablet and things like that. I think you need to be guided by what you're happy to advise the patient. And you can build it. So sometimes that won't be enough. But interestingly, I've had patients who feel much better on the lower dose than the higher doses, whereas previously they may have seen people who keep putting up their SSRIs, and actually then they just have lots of side effects, which they don't really want to have to deal with, and it can affect things like sexual function and other things, which causes them further distress. Having the lowest dose and then just thinking, actually, we have got room to increase this, I think is often the way to go. So and there are studies out there that do show that 60 to 75% of patients with PMDD, so the more significant form, will have a positive benefit from trying the SSRI. Said not everybody will want to go down that route, and if you've got irregular cycles or you're more perimenopausal, it's going to be harder to do that luteal phase on and off, because if you don't really know when you're ovulating, that's quite hard. So sometimes you might want to try, it could be daily, it can be given daily, and some patients do prefer that because they might forget to take it, or they just think it's just easier. So it's on an individual basis. The pill can be used, but it needs to be used where we take it back to back. So not the traditional way the pill was used with the 3 weeks on, 1 week off, because then you're just going to mimic a menstrual cycle, or trying to do that. You're having 3 weeks of high dose hormones, taking it away. And in a brain that is really hormone sensitive, that can almost make things worse for patients. So often trying it back to back, and sometimes obviously you will need to take a short break if there's persistent breakthrough bleeding, which can become difficult to manage. But often you can do that tricycling, so you can run 3 packs together, have a 4-day break, and then restart. And having that 4-day break is often, it's a short enough time that things aren't too difficult to manage, but it's enough time to kind of reset things as there has been a bit of a breakthrough bleed. But the type of pill we use is important. Some women are particularly sensitive to the progestogens that are in that. So not all pills are the same, as you're aware. And often the ones we start with by standard are not the best for patients with PMS. It really depends on the progestogen. So often I would use the ones that have got the drospirenone as the progesterone in that. So you've got things like Lucet, Eloine, things like that can be helpful. There's a Australian psychiatrist who uses Zoli, and there seems to be good at, that can work quite well if other ones don't suit patients. But again, if somebody is struggling with skin issues for their premenstrual symptoms, something like Zoli wouldn't be helpful, because the progesterone in that can actually worsen the skin. And I think this is where it can become quite complicated, and where 10 minutes in general practice isn't really enough. But I think starting with a drospirenone-based pill would be a good thing. The other option is something like the Mirena coil or the IUS, which can give you stability. It acts as obviously contraception. You don't need to take a break at any point, and using estrogen patches or gel like you would do for HRT and menopause, that's also in the guidelines. And if at a very severe end, when you're getting into PMDD territory, you might refer on for other things, but we can talk about that.
So PMDD, it keeps coming up, and I'm already quite concerned that it sounds like quite a serious problem, and yet I don't think I can recall a particular consultation with a patient about this in particular. So now I find myself wondering, is it very rare, or are we missing it as GPs?
Okay, so PMDD stands for kind of premenstrual dysphoric disorder, and it's not rare. It is the most severe form of premenstrual disorder. It's mentioned in the RCOG Green Top guidelines. It affects, we think, around 1 in 20 women, and those assigned female at birth. So you have to remember, it obviously it can also affect trans men. It can affect non-binary people as well. Anybody who's been born with female reproductive organs, this can affect. And again, this is really a matter of degree. Like we said earlier, when would you go to the GP about PMS symptoms? Well, if it's affecting your quality of life. And PMDD, I suppose the difference is it's the severity. And people with PMDD, it's when it's really about affecting your ability to function. It's recognised in the DSM-5, but also the World Health Organization is now listed as a medical condition on the ICD-11 as well. And this is because it has a significant disease burden. It can really affect somebody's ability to function in their work life, their home life, their social life. And the predominance of symptoms is psychological here. So yes, a lot of these patients may have breast tenderness, bloating, joint pain, things like that. But actually, really what brings them to the doctor for help is the suicidal thoughts, which can recur month in, month out, feelings of hopelessness, significant anxiety, rage, terrible brain fog, awful insomnia, or sometimes hypersomnia, where people can't actually rouse themselves to get up for work or do anything. This condition can lead people to walk out of long-term relationships, or, partway through the month, then come back thinking, what the hell happened? So a lot of patients will say to me, it's like a light bulb goes, a light switch goes on or off. I wake up one day and I know the world feels terrible. And then when the period comes around, they're like, and I feel so much better. But then they have to spend the rest of the month trying to pick up the pieces. They say they can feel completely out of character, but it feels out of control. Tends to be a genetic predisposition to this. And some patients can have, say, milder PMS symptoms in their, say, teenage years and 20s, and it may develop into PMDD in later life. And I think that's probably where we see the influence of things like epigenetics, or where the environment is affecting your genetic predisposition, and where things like how you eat, how you manage your stress, whether you exercise can influence it. But it's not. I would never say you're directly responsible for causing that. It's so complicated, and there's so many other factors. It's also associated with trauma. So if you have a PMD diagnosis, there's more likely to be a history of trauma. But trauma covers so many things, doesn't it? It's not just, say, physical or sexual abuse in childhood. It could be the grief of losing a parent, or being admitted to hospital with a physical illness when you're younger, being bullied at school. All of these things come under that umbrella. So there's a lot of people, probably everybody has got some element of trauma in their life. But PMDD awareness is so important because it's basically suicide prevention, because 1 in 3 people with PMDD do attempt to take their life. And I think if we can do anything to raise awareness of this condition and let people know that there is help, then that will make a massive difference.
So if we pick up a patient that we think is suffering from PMDD, should we be starting the process of helping them as a GP, or should we be referring on early?
I think it depends on the severity, to be honest. A lot of the patients that I see have tried a lot of stuff themselves, and I might see people at the much more severe end. But certainly sometimes things like the trial of the SSRI could be revolutionary for these patients, even with the most significant symptoms, if they've not gone down that route already. Unfortunately, a lot of people only really try and get help when they're particularly desperate, or they may have been wrongly treated for chronic anxiety and depression, which, when it's really been PMDD driving it and leading to that, rather than the other way round. And they may be reluctant to try something like the SSRIs, or they've tried different pills that have made their symptoms worse because it's had the wrong type of progestogen. But you may, especially because there's more awareness on social media now, so you could get a young woman in her late teens, early 20s, who's like, I think this is what I'm got. I feel utterly awful, or I always have a fight with my boyfriend at this time, or I can't study, or I have a massive row with my parents every month. Then you think, actually, we can do this. And also, again, finding out a bit about what they're eating, what their diet's like, what their lifestyle's like. So the most significant symptoms can respond to small changes. So I think it's meeting the patient where they're at, really. But you have got the toolkit in terms of, if you're looking medically, you've got the SSRIs, you've got the pill, you've got HRT. I think if you've got somebody who is very suicidal with intent every month, then they do need, as you would do with any patient, they do need referral for secondary care.
Can I ask, how would we tell the difference between, say, a clinical depression or even bipolar, maybe? Because I can recall some patients coming and saying, I think I've got bipolar because I'm so up and down. And now I'm thinking, gosh, have I missed PMDD?
Yeah, well, we're not really taught about it, though, are we? I wasn't taught about it at medical school. It's about tracking again. And that's again the clear bit. There's a good diagram with the green top guidelines where you can kind of see, you try and differentiate between the different types of premenstrual disorder. So I think it's quite clear. So it's, if things return to complete baseline, you can have quite a clear cut pic, in the follicular phase when you start your periods, then it's quite clear cut. But the thing is, nothing really is ever that clear cut in medicine, is it? And people come with all kinds of things, and a lot of patients who've struggled with premenstrual disorders for a long time, or premenstrual symptoms, they are going to have symptoms a lot of the time. Maybe they've been dismissed, they've not been believed, they're on some medication that's actually contributing to their symptom load. I think, though, if it looks from a practical point of view, if there seems to be a cyclical element to it, I think using the principles around managing all the premenstrual disorders is the way to go. Because if you can stabilise the menstrual cycle or improve the way the body metabolises the hormones and therefore mitigates the brain's response, I think that's helpful. All of us are quite bad historians. You can't often remember exactly what's when. And most of the time when I have a patient date, it's very clear, but very occasionally, somebody will show me a diary and their mood is all over, their symptoms are all over the place. And you can say, well, actually, I don't think that this is primarily driven cyclically. So let's look at other things first. We can always come back to that. So that's the key thing for both patient and doctor, I think. The other thing, you could start this in general practice, but you may want to refer on the GnRH analog. So what, that you use to switch off the ovarian function. If there's diagnostic uncertainty or symptoms are incredibly severe with PMDD, but you'd probably refer to a gynecologist for that. Generally, you would be referring on for that. I think if you're very worried, you can jump further down the treatment ladder, even if somebody's had no treatment. I've seen some patients who have ended up in, CAMS, they've gone to psychiatric units because they're so unwell. So I think those patients, as much as we can say, have a good sleep-wake cycle, go and eat more greens, we need to make sure they're safe first, and then we can work on that. But I don't know if we've got time to speak a bit about why the plant-based diets might be helpful, because, I found this with anybody from the mildest PMS symptoms up into the most significant PMDD symptoms, really. Do you recommend stuff to your patients particularly about that? Or
No, to be honest, I know that we're going to talk maybe about painful periods, and I will come out with some facts about how plant-based diets seem to have an effect on reducing the pain that people get with periods, but not for the general symptoms. And I know that perhaps maybe if we talk about the metabolism of some of the hormones and how they are taken out of the body, and how maybe the microbiome might help with that. What do we know about that?
Yeah, well, what we do know with premenstrual disorders is that there seems to be, and also with the change in the menstrual cycle in somebody even without a clinically significant premenstrual disorder, is that levels of inflammation go up in the body prior to menstruation. So anything we can do to reduce inflammation is going to be helpful. We know that a whole food plant-based dietary pattern is anti-inflammatory. So the more plants, the more fibre we have there in the better, and the better the health of the gut microbiome. There seems to be better symptom control. There's lots of reasons why that may be. Some of it is to do with the enzymes that we find in the gut, which is influenced by the gut bacteria. So if you have a fibre-rich plant-based diet, we know that you've got lower levels of beta-glucuronidase in the gut, and this prevents estrogen, for example, being reactivated in the gut and reabsorbed into the bloodstream, which can trigger further fluctuations and can increase something called sex hormone binding globulin, SHBG, which it almost acts as a bit of a mop-up for extra hormones in the body that can provide stability. There's a flip side to that, because you don't want super high SHBG, because things like levels of testosterone can be lowered as a result, but that's probably, we can park that for the moment. But essentially, what we're trying to do with PMS is minimize the fluctuations, having that buffer in the blood, like a decent level of SHBG, reducing the reactivation of the breakdown products of estrogen, whether they're our own or for what we've taken through the pill or HRT, for example, that's going to be helpful. So we know that then there's something called the estrobolone, which is the fact that gut microbes have an effect on estrogen production and synthesis. And we again know that the benefits are of having more of a diverse microbiome there and providing the healthiest kind of environment for that. So that's really helpful where the microbiome comes in. There's also the influence on things like the COMT and DIM pathways, and that's specifically about estrogen metabolism. The brassica vegetable family are particularly helpful there. So particularly like broccoli and things like that, the other cruciferous vegetables can be helpful. So I often recommend that. I mean, you can buy a lot of these supplements, can't you? Like dim, and it's basically broccoli, greens and stuff. So increasing greens in your diet can be incredibly helpful from that point of view. Things like polyphenols found in lots of the dark kind of fruits and things like dark chocolate can be particularly helpful at reducing neuroinflammation. They can act as adaptogens, which means that your body is better able, and your body and brain are better able to withstand those fluctuations. I'm just trying to think. There's so many things that we can. Or they also help support the tryptophan pathway, which affects serotonin production. And most of our serotonin is actually produced in the gut. We've got 95% of the receptors there, which is why when people can often start SRIs for depression or anything, can feel a little bit nauseous. First of all, you increase the level of the serotonin, can make you feel a little bit sick, because there's the gut-brain axis and the psychobiome. There's so many different ways that the micronutrients and everything in a plant-based diet can affect the hormonal pathways, metabolism, the excretion, and how the body deals with fluctuations. So, and lowering that overall level of inflammation. And there's certain foods that probably do worsen things for people. So dairy, particularly, the A1 casein protein is going to be particularly inflammatory. And I found, and I think it's a lot of clinicians I know work in this area, found that often a dairy-free diet, even just that alone can make a big difference to symptoms, whether it's heavy and painful periods or it's the psychological side of things. And sometimes it can be that dairy can be quite high or provokes quite a big histamine response, which is another thing that can influence premenstrual symptoms. And that's where sometimes, I'm going off on a slight tangent, but things like sometimes I use antihistamines for patients just in the luteal phase, or again, reducing histamine high foods. So things like that's again where alcohol comes in, things like processed meats, salted fish, all of these things can promote a higher histamine response. There are some plant-based foods that can also do that, things like avocado, but it's definitely more of the processed and some other foods that can kind of promote the biggest response. So
yeah, I mean, it sounds like there really is much more evidence than I was aware of for talking to people about diet as part of their lifestyle. It's all part of how to feel better in
exactly.
terms of your hormones.
Exactly. And I think essentially the dietary pattern that is going to be beneficial in menopause or PMS or PMDD or endometriosis, there are some subtle differences, but essentially it's a dietary pattern rich in plant foods, and the reasons are across the board.
So that's really fascinating, Hannah. Is there anything a plant-based diet can't do? That's what I'm thinking at the moment. You mentioned painful periods and endometriosis briefly. Can we just touch a little bit on that? And because I was wondering, actually, could PMS cause painful periods, or should we be thinking about other diagnoses?
Well, it can be part of it, but I see a lot of patients with the most significant PMS often do seem to have endometriosis as well. There can be some shared genes there that may be playing a part. But yeah, I mean, it can be part of it. And I don't think it's necessarily abnormal to be slightly uncomfortable, but if it's to the point that you're having to take painkillers regularly, or you having to avoid school, work, social functions, because that's a completely different thing. I mean, menstrual cramps, unfortunately, are probably part and parcel of being female to some degree, but particularly in the early years, just because the uterus is changing and responding to the transition in hormones. But if they're mild, they shouldn't be stopping you doing anything. Certainly diets can improve things. So again, dairy can be something that's particularly problematic for patients who have problems with, cramping period, pains and stuff around then, maybe to do with the prostaglandin production, which it ups just before your period. So yeah, changes there can make a big difference. But if we can talk about endometriosis, that's a completely different thing.
Yeah, so for people who might not be familiar with endometriosis, can you give us a brief outline of what it is and how we would diagnose it?
So it's a condition where endometrial-like tissue, so that's tissue similar to the lining of the womb, are found elsewhere in the body. And it affects around 10% of women and those assigned female at birth, but it often takes a long time to diagnose. It's also been recognised as a systemic disease with a chronic inflammation. And it has actually been found in people postmenopausal up into their 80s and 90s, including some men. So although it predominantly is going to affect females, And maybe that's something to do with what happens in embryogenesis. I don't know, all of this stuff. Like, we have seen it in men. So, but it's primarily going to affect women. It can be a very debilitating condition. So the most common symptoms are significant pain just before periods and when you're bleeding. But it can also cause pain on opening your bowels, pain with sex, painful urination, chronic fatigue, low mood. It's difficult to know, is that some of that because you're living with chronic pain, or is it because of the chronic inflammation, which is impacting the brain in that way? Infertility. And some women, interestingly, may be infertile, and they're only found that out when they go for infertility investigations. They then discover they've got endometriosis and they don't have pain. So endometriosis isn't always obvious. I mean, pain's one of the most significant things, but not everyone has pain. And I think it depends on how it's impacting nerves in the pelvis or elsewhere. So when you look at the grading and staging of endometriosis, you could have very severe disease surgically but minimal symptoms, or you could have technically mild disease but debilitating symptoms. It's quite a tricky condition to manage and is still under-recognised. So
Yeah, and I think it's part of the reason why it's under-recognised or under-diagnosed is, I mean, certainly for me as a GP, I feel a bit frustrated. I can't just order a blood test that will show it, or often it's not even apparent on an ultrasound scan. And I think to send my patient up for quite an invasive procedure to have a diagnosis, procedure like, say, a laparoscopy, is that the only way of diagnosing it properly still at the moment?
yeah, I mean, that used to be, we said it was the gold standard for diagnosis, but the guidelines are quite clear that you don't need that for diagnosis. So you can have an ultrasound which can sometimes pick up big endometriomas, but a negative ultrasound doesn't exclude endometriosis. And I think with everything in medicine, it's a risk of benefit thing, isn't it? So sending somebody for a laparoscopy, which is obviously under a general anaesthetic, it's got all the risks of surgery, that doesn't really make sense if you can try stuff that could improve the symptoms. I know some patients will want, is this definitely what it is? But ultimately, is it going to change what we do? They still recommend laparoscopy if there's diagnostic uncertainty, if things aren't improving. But there are lots of things that you can do. So sometimes, for example, taking painkillers, particularly the non-steroidal anti-inflammatories, in the 5 days leading up to your period can reduce your prostaglandin load. Also, doing that, or maybe changing your diet. I've had some patients who actually just changed their diet just before their period. So they will cut out all animal products, or they'll cut out all dairy, or cut out all meat. That will make a difference to their pain that month. And if they slip back into eating a different way, they notice it the next month. So there's lots of ways you can kind of do that. Dietary, lifestyle measures, taking prophylactic painkillers. And it's important to start them before the period, because it's too late by the time it's arrived. There's already had that prostaglandin build up. Hot water bottles. There's evidence that exercise can help. Maybe it's because it influences the level of inflammation, but that's quite hard for patients who are having very significant symptoms, or they may only be able to exercise after their period has finished. And then again, when you're in that luteal phase, when symptoms ramp up again, it can be quite hard to be consistent. And that's where you often need some of the medical treatments. And to be honest, a lot of it can be managed in much the same way as PMS and PMDD, because what you're wanting to do is manipulate the menstrual cycle. So the SSRIs don't really have a place here unless there's concurrent depression and anxiety, but things like using the pill back to back, because what you need with endometriosis is a stable hormonal playing field. It's the change, the up and down. The hormones don't cause endometriosis, but they can drive the disease. So the tissues are responsive to changes in estrogen. So often you can find women who maybe fall pregnant with endometriosis are symptom-free during their pregnancy when their levels are high and stable, but they start up again when you have these regular cycles. So having back-to-back pill, the Mirena coil, that can be quite helpful, particularly if the disease is local to the uterus rather than, I mean, if you've got endometriosis and it's in your lungs, that's going to use a different approach, but that's quite rare, but it does happen. And again, the GnRH analogues, which switches off ovarian function for very severe symptoms, but those will be ones you'd be referring on to. You'd need, if things don't improve with dietary changes and lifestyle measures and painkillers, or things like TENS machine, which can sometimes help with moderate the pain response, then you probably would be looking at referring on. The progestogens or natural progesterone can be helpful with managing the pain because it can counteract any estrogen that may be driving the disease as well.
When you say natural progesterones, what are we talking about here?
So progesterone, like utrogestan, as opposed to the progestins that are in a lot of the others, but the progestins do have a place. It's just, it's about side effects of, and some women, if they've got concurrent PMS as well as endometriosis, may not respond to some of the older progestins that we can prescribe. So
Okay, that's interesting. I don't think I've ever used estrogen other than in a sort of perimenopause or menopausal prescription, but
well,
that's
there's
really...
also, there's pessaries, it's like cyclogest is licensed for PMS, and I don't think we don't tend to use that for that now, but you can use that as a vaginal pessary or rectal pessary in the luteal phase. A lot of the newer evidence, also this is more for PMS now, but a lot of the newer evidence for that, it says, oh, there's no place for that, but I find it's very patient dependent. But there are lots of, you're probably getting more into specialist territory with things like that, to be honest. But there are lots of options. I think that's kind of a good message to get out.
Yeah, brilliant. Thank you. I know we've kept you a long time, but we can't really let you go without speaking about your book and your expertise, particularly in an area called POI, in premature ovarian insufficiency. And I know you've shared your journey with your own health in other podcasts. Would you be happy to talk a little bit about that before we round up?
Oh, well, yeah. So POI stands for premature ovarian insufficiency, as you said, and it essentially means loss of ovarian function and those hormones below the age of 40. And this actually affects a large number of women and girls, and more than we really realise. So we would often say it affects 1% of women below the age of 40, but actually we think it's closer to 3 to 4%, depending on the cause. So that this can happen naturally, as in the ovaries, for whatever reason, may just cease to function properly, and we don't always have a reason for that. It can be linked to autoimmune causes, so kind of autoimmune thyroid problems or adrenal function or celiac disease, type 1 diabetes. It can be linked with genetic changes, so Turner syndrome, Fragile X, infection, particularly in the developing world, so TB. Things can influence this. In pollution environment can affect things. So actually smoking increases your risk of developing ovarian failure or POI. And air pollution in places in India, for example, there's much higher rates of it in places where there's high air pollution. And we know that high levels of air and particle pollution affect quality of sperm and eggs. So it seems to affect reproductive function and can have a knock-on effect with things like POI. But most of the time in the UK, for example, you won't find a cause for it. There may just be a family history, so there could be a genetic link. It can then also happen as a result of cancer treatment. So somebody who may have gone through radiotherapy as a teenager or have had particular types of chemotherapy could have damaged the ovaries and they could stop functioning. Or it can happen when we place, this isn't technically POI, but it places people in a medical menopause where you shut down the ovaries, whether this is for kind of a cancer treatment or severe PMDD or endometriosis. We have medications to switch off ovarian function. Or in my case, I had my ovaries removed, so that put me in a surgical menopause, which isn't the same as POI, but the modern terminology is surgical POI because you're still somebody under 40. When I had it, I was under 40 and had no ovarian hormones. And ultimately, there's a large number of us who are affected, and it's not just about the symptoms you get, which are very similar to the symptoms you're going to get as an older woman going through a more natural menopause transition. So things like, it can be the hot flushes, it can be vaginal dryness, it can be mood changes, insomnia, joint pain, things like that. It's also about your long-term health, so protecting the health of your bones, your heart, your brain. And we know if we don't replace those hormones, that can be really detrimental to your well-being, both in the short term and long term. Of course, there's a group of women who may have an estrogen-independent cancer, and maybe that's why they've ended up in POI. And I just want to reassure them that there are options that you can do. Again, diet and lifestyle are big factors there in protecting your bone health, your heart health, managing symptoms, and there are medications that can help. So I wrote the book, which is The Complete Guide to POI and Early Menopause, with my friend, Dr. Mandy Leonhardt, who's a GP, and she's also a nutritionist and menopause expert as well, because we felt there was nothing really out there for women like me and so many others. And so we looked at the whole thing, and also the psychological impact, because it leads to a feeling of grief, loss of identity if you haven't had children, and you're out of step with your peers. It's a huge topic. I think it's just worth knowing about that people aren't alone. There's the Daisy Network, which is the charity. for women with POI. So there's lots of stuff out there. And the book that we wrote, obviously it's available in bookshops, but you can order it from the library as well. So
we'll definitely link that to the show notes, because I was looking at the reviews, and fantastic reviews about your book and how, as you say, it's touched people from a psychological and emotional perspective, as well as giving them all the medical evidence and the information they need. So I'm definitely ordering a copy, having read those reviews. And thank you for sharing your journey. I just felt like we've learned so much, and it's been really, really interesting. Just before we go, two things. One is what you're having for dinner, but also you are consulting, aren't you? So if you can tell us before we go on to food, where people can find you if they've read your book and they perhaps want to consult with you as well.
So I've got a website which is just drhannahshort.co.uk. So, and I've got various resources on there, whether it's about PMS, endometriosis, POI, things like that. But I now practice with a team of doctors. It's under the label Menopause Care, but I do see patients with PMS and other things there. So the link to that can be found via my website, or you can search for me under Menopause Care. But yeah, my website will take you where it is. So,
oh, we'll put all of those in the show notes. Wonderful, Hannah. Yes, and so our favourite topic, coming back to food on this pod, what are you having for dinner?
Well, I knew you were going to ask for dinner. Actually, we're going out for dinner tonight. So I think maybe I should tell you what I'm having for dinner. Because we're going to a talk this evening. It's a Norfolk and Norwich festival. So we're going to an author event. And we might be going out for a night. There's a great restaurant in Norwich that does amazing kind of plant-based Japanese food. So I think we'll be going there. But I'm planning to make tomorrow is a nice white bean stew with kind of rosemary potato wedges, which baked in the oven. So it's a stew that's full of 5 different types of beans and also some greens and lentils, and so it's full of like fibre and thing. It's really tasty. I know I love beanie things, so that's what I'm going to be having tomorrow.
Sounds lovely. I'm glad we managed to get beans into this episode, because we have to get beans into every episode, I think now, Claire, don't we? Sounds great. What about you, Claire? What are you having for dinner?
Well, I'm still under the illusion that I'm going to eat even more healthily and improve my running. So I'm back in the Power Foods cookbook tonight, it's asparagus season. So there's a recipe which is chickpeas, asparagus, and just some whole wheat pasta. And you cook everything together. I think there's a red pepper goes in there as well. You cook the pasta, you put in the veg a couple of minutes before the pasta's done. And then while the pasta's cooking, you make something called a chimichurri sauce, which is basically just parsley, garlic, some red wine vinegar, and some lemon juice and salt and pepper as well. You blend it all up and then drain everything, and it goes over there, and it's just a delicious, colourful pasta dish.
Oh, that sounds
That's very healthy, with all those chickpeas in there. It's great.
That's gorgeous.
Daisy,
Is that from Dr. Neil Barnard's book, the Power Foods book?
Yeah, that's the one I'm using at the moment. So I mean, that's how I roll. I tend to sort of hang in one cookbook, and then I kind of go, oh, that was good. And then I think what you're supposed to do is put your post-it notes in there and say, yes, I really enjoyed this. I made this adaptation and stuff. But I tend to be a bit fair weather with cookbooks. I'll move on to something else eventually.
Oh, but we love Dr. Neil Barnard, so we'll probably link that one in the show notes as well if you recommend it.
Yeah, I definitely recommend it. And it's got all the kind of good stuff about, why it's not a good idea to eat dairy and things like that at the beginning. So there's really good nutrition knowledge in there as well. So, but Daisy, what are you having? You've always got something good, because you say it's Friday. It's not enchiladas night, is it?
It's not enchiladas night, but I can't remember whether I've spoken about this one on the podcast before. So if you've already heard this, I'm really sorry. This is one of the favourites, so I might have already told you about it, but I will give a little bit more detail than maybe I have done before. It's tofu koftes. So they're like Turkish style little kebab things, and I make them with tofu. They're actually from an Instagram recipe. Ben's Kitchen, I think he's called. He's a really excellent sort of vegan influencer, chef, I don't know, Instagrammer. And it's really simple. So you just sort of crush up your tofu. You just sort of, with your fingers, you can just crush it. And you add lots of fresh herbs. So whatever you've got, I like mint and coriander chopped up fine, spring onion, some tomato paste, and any spices that you like. So I like cumin, paprika, salt and pepper, and a little bit of flour just to bind it. Then you just sort of squish it up like you would a kebab, I suppose. And then you can pop that in the air fryer or fry it in a little bit of olive oil. And it's really, really delicious. That's why it's on repeat. We all love it. And we have it with hummus and salad and flatbread. So.
Oh, you two are inspiring me. I need to do different things, I think.
So we just wanted to say a really big thank you again, Hannah. Thank you for your time and your expertise. It's been really fantastic talking with you today.
Oh, thank you. It's been a real pleasure.
And you've motivated me to go back to the guidelines,
Yeah.
which is always good. Yeah.
Oh, I could share some websites that could be helpful for people if they're struggling with the most severe symptoms, like IAPMD, which is the International Association of Premenstrual Disorders. I can send them to you for the show notes if you'd like as well.
Yes, please. Right.
Thank you. Thank you for listening to the podcast. We aim to bring you the most up-to-date evidence-based information about the benefits of a plant-based diet, and we'll add all the links for further reading in the show notes. Please remember that everything discussed on here does not constitute individual medical advice, so please consult your healthcare provider if you have any medical concerns.
In the meantime, please subscribe to the In a Nutshell podcast on your usual streaming service and download our future podcast for free. And since food can be the best medicine, don't forget to share us with all your colleagues, friends and family. Until next time.